eGlobalDoctors, in association with American Association of Physicians of India, and SEVA International, working to provide this session. Today in this video, we have an expert, pulmonary critical care specialist Dr. Prasad Garimella, from Georgia, USA. He has been practicing since last 17 years. Also he is making novel contribution to the society as a frontline worker, since last 1.5 year. Dr. Prasad will be presenting in session that will guide you through all the phases using which we can control the COVID crisis. So without any further delay, let's start the session.
I'd like to introduce our expert, Dr. Prasad Garimella. He's a pulmonary critical care sleep medicine specialist from Lawrenceville, Georgia. He graduated from Cornell Medical College with honors. Then he's been practicing here for about 17, 18 years. So he does a great job with as a frontline worker for the last year and a half or so. And he gave so many webinars. So we learned so much over the years, not only for us, he also gave the talks to the Indian critical care specialists and the pulmonologists there to take care of the patients there in India. Thank you, Prasad. Please take over.
Thank you, Dr. Gangasani. I really appreciate this opportunity to reach out to more doctors, through that more patients, to stop this pandemic. My personal request is I represent SEVA International, which is a charity organization. And, I want everybody to see if you provide any kind of your time, effort, or money, or any kind of an attention that you can provide. So before we start the presentation, I request your higher selves to consider in this pandemic times, to consider SEVA International as one of the service organizations that you can contribute to. So we have a Doctors for SEVA WhatsApp group. So if you can, join, that would be fantastic. So as far as this orientation is concerned, or what we are trying to do is like knowledge exchange. So one disclaimer I have before I start is like, this is not complete, comprehensive. Everybody is an expert in COVID nowadays. You have WhatsApp universities, YouTube universities, and also on the other hand, nobody is an expert. We are all in the medical school together. So having said that, what I'm trying to focus is in what we can achieve in 10-minute consultation, and what our purpose or main goal of this telehealth visit that we are trying to do. So the main purpose of this objective for this is that we are going to find out who are the patients who can stay at home, so that we can decrease the burden on our emergency rooms, our hospital beds, and our ICU beds in India, so that the downstream consequences of oxygen use will be decreased, so that we are giving a helping hand. So we're not going to talk about the hospital management. We're only going to focus on the COVID patients who are at home, and to kind of guide them, assure them, decrease the anxiety, decrease the panic, and at the same time, give them the good information. What would be considered good information is like, when we look at it, talking to multiple families, multiple COVID patients, these are the three questions that come up mainly. So one question is about the triage, whether they need to go to the emergency room right away or look for the bed. So that is an acute question right now. And then the second question comes up is, what is the prognosis, and how best you can guesstimate or estimate that prognosis from our analysis. The third question is this the right treatment that we are getting, or anything else we need to do? So we are setting up with these three questions in our mind when we reach out for this patient. So when we have those clinical questions, so rest of the discussion will basically be dependent on these, what we are trying to achieve. So for us to achieve that, we need to get the information. When we get the information in that 10 minutes, we are going to collect them in such a way that we can kind of take the flow nicely through that evaluation. We all are experts at it. I'm only going to redirect them one of the ways that is working for many of the doctors. If you have any suggestions, please suggest to us, and we can always improvise on that. So the 5 layers of complexity, how we are going to come to answer those 3 questions for an individual patient are: One of them is the demographics and the past medical history, the medications and other information. The eGlobal platform will be able to provide that information for us in the form of volunteers collecting that information ahead of time so that you are not asking that patient. So the key is that you get to the answers as quickly as possible because the doctor's time is the most valuable in all this. So the eGlobal platform is one of the perfect platforms where you can quickly gather that information, analyze it, process it, interview the patient, and then answer those questions. So the first layer where you're going to collect the information or first thought box you're going to put in is that demographics information. So the second one is basically the past medical history. So whether they have underlying lung problems, heart problems, diabetic problems, history of blood clots in the past. Sometimes, in India, you see a lot more of tuberculosis or chronic conditions. So you need to know that piece of information is going to be important. So the demographics and past medical history will be in that information, right? So the next box, which is the second layer of complexity, is going to be about the symptoms. So let me tell one more thing about the past medical history is that the predisposition is the key, whenever we address any infectious disease. So if the patient is neutropenic, you give different kind of treatment, whereas if it is a community acquired infection. So that's the importance of why you are collecting what the predisposition of the patient is. That's the focus on this one, and to know a little bit about their smoking history, their allergies and all that. So now let's move on to the second layer, where the second thought box, where you are going to collect that information. So here, the most important thing is, when did the patient have the symptoms onset? Most of the time they can tell. Sometimes, especially in the asymptomatic patients, the day of their symptoms may be the day they got it tested, because they cannot really pinpoint. But majority of the time you have, symptom onset is there, fever started on so-and-so day. So this is very important piece of information that you're going to collect, mainly because that is what determines what phase the patient is in that COVID disease. The first 7 days roughly is about the viral phase, where the replication is happening. The second phase is where the cytokine or inflammatory phase is happening. That's when the lymphocytes are being recruited, and then more and more lung damage is happening, mostly through this cellular immunity. That is the second phase. The third phase is mostly after they have a severe illness and then they end up with fibrotic stage. We're not talking about that fibrotic stage unless you have a patient you are seeing 28 days, or they already had a post-hospitalization follow-up visit with you. So those are the three phases. For you to identify it, whether they are in the first week, second week, or few weeks later, that's what the onset is important. The other symptoms we all know, the shortness of breath, the cough, the fever, and other things. So we need to collect that information. That's the second layer. The third layer is, let's move on to the third box, is basically the oxygen information, sorry. So the signs. So the oxygen information is going to be the key. Here, the key part is like to educate the patient and get that information properly. One of the things that we focused on is like in this interview process is like to collect the right information as far as their physiological status is concerned. So you are going to ask the patient to put the pulse ox on their finger, keep it on for next 6 minutes or so, collect the oxygen and the pulse rate at baseline, and then you are going to ask them to walk. If they are in quarantine, small room, they can walk in the same area multiple times while they are monitoring this oxygen and pulse rate. And then they rest. They keep that on while they are resting after that 6 minutes, and then still see what the highest heart rate or the lowest oxygen pulse ox level they are at. And then they're going to document it. If they document that information, right, so they will have 2 times a day, they will have 14 of these points. So these 14 points, data points, are going to be the key for us to know whether they are getting better or not. The trend is a friend in this scenario. So that one of the important pieces that we need to educate, collect, and that will be a good decision-making point for us in this box. So the next one, let's move on to is the labs. So when we are talking about the labs, there are a lot of the lab data. What we're trying to achieve, I'm not talking about the hospitalized patients. These are the patients who are at home, COVID positive, waiting for their, trying to decrease their anxiety. So when you are talking about CRP is one of the important things. So in CRP measurements, if you are measuring in milligrams per deciliter, up to 6 is normal, less than 26 is mild, 26 to 100 is moderate, more than 100 is severe. So this is key information based on your oxygen saturation, based on the lab information, and based on the imaging information. You will be able to decide what stage they are in. Is it mild, moderate, or severe? This is the key information. On x-axis, you have a time, which is viral phase or inflammatory phase or fibrotic phase. On the y-axis, you are going to decide whether they are on mild, moderate, or severe. So the lab data, whether you put them into these categories, is going to help you to figure out what stages are on. So if you take the CRP, you have these already, we can share this data. So with the CRP, same thing with ILD, based on the levels, you can say whether they're mild, moderate, or severe. And similarly with the D-dimer, you can do that. So these are the important lab data that you can trend and track and trend. So that will tell you which stage. One is the phase, other one is the stage. So how much degree of involvement they have. And then the fourth one, let's go to the next layer or the box, third box, that's imaging. So in this one, there are few of these data points. Initially, about a year ago in India, they were all going by this CORAD score when they were not having the lab tests easily available. They were using the CT to know whether the patient has is COVID or not, just based on the CT findings, the ground glass infiltrates. So that CORAD score is 1 to 6. If the patient is already COVID positive, you don't need to worry about CORAD score, right? Here we are seeing the patients who are already COVID positive, most of them, So that's why, but it's important for everybody to know what the CORAD score is. It's a suspicion of COVID in a patient who did not have the laboratory confirmed test. If they already have a laboratory confirmed test, this is not necessary. On the other hand, there is another score that is commonly used in India, not so much in America, but it's called the CT severity score. Less than 8 out of 25 is mild, 9 to 15 is moderate, more than 15 is severe. So now you see the trend, both in the oxygen, in all these three things, right? So oxygen saturation, whether they're just dropping or not, it will tell you whether they're in the mild, moderate, or severe. Then the labs will tell you whether they're mild, moderate, or severe. Now you're going to take this third piece of information, which is the imaging, if it is available. Not all the time you have this. So once you have this, all three are pointing towards mild, you can say that the patient is mild, and that will be very useful. So that's the next layer of the box. So let's go to the last one. Once you have all this information, then you are going to answer those three questions. Can you flip the page, please? Next page. So with regards, before they do that, with regards to this oxygen concentration, when especially exercise oximetry, it is very important, because if they do that oximetry, they will know what is going to happen in the next 24 to 48 hours. That's why it is such a prognostic tool. We walked you through these 5 layers or 5 boxes, thought boxes, where you're going to put this information together. Once that is available, you are coming back to those 3 questions that we started out with, triaging. So if they're mild, they can continue to be at home. If they're moderate, you can see you can give parameters at what point they need to go. And then obviously with that severe, then they need to be in the ICU. And that's the key point, right? That's a triage question. Our main purpose again is to make sure that the patient who can stay at home stays at home as long as they can. And we are giving these parameters what they are going to look at. And the second question that about the pulse ox that comes up is that at what point you need to be worried about. 94 is the accepted one, but certain patients, especially the COPD patients or somebody who has chronic lung disease, they may be 94 at baseline, but you are looking at when they are walking, if they are dropping further down, 4 points below their baseline, if they know their baseline. If their baseline is 92, and you don't want to send everybody who is at baseline 92 to go to the hospital. So those are the two key points as far as oxygen is concerned. So the next question we need to answer is prognostication. It is basically extension of the triage question that we talked about earlier. Basically, whether the patient, how they are going to do well or not. So the example that I give is like a few days ago, we saw this patient on teleplatform on eGlobalDoctors, 80-year-old, who's already finished 16 days. And symptoms-wise, they are coming down. The next box or next layer is her oxygenation. It is not dropping, it is stable. Labs-wise, her CRP is coming down. Then imaging-wise, they had these 2 data points. So at the end of it, we were able to prognosticate and say that she's already past that 2 weeks phase and she is stable, only requiring a couple of liters of oxygen and not much of a decline. So my estimate is that she will do well, 80% chance that in the next 2 weeks, she is able to come back to her baseline, slowly improve. And that was very important for the patient family because we are relieving not only patient's anxiety, family's anxiety also. That's the second question that we are going to answer. The third one is going to be the treatment. They are going to ask us whether the treatment they are getting is appropriate or not. So whenever we are doing this treatment or management, is like there is pharmacological treatment, non-pharmacological treatment. So in the pharmacological treatment, Srini, can they get that other side of this yellow paper, Ganeshji, if you possible? So the treatment-wise, we are talking about the common ones that we use in India. So you have this ivermectin. A lot of people, you're using it as a prophylactic and, and then also as treatment. We talked about Plaquenil earlier. Nobody is using it. Nobody is recommending it. There are still present in certain of the protocols and guidelines. As you know, there are so many protocols and guidelines. So here we are not advocating anything. We're just assuring the patient that whether they are using these things are appropriately or not. If second thing that comes up is antibiotics. Antibiotics are used left and right. Some of the patients are on double antibiotics, doxy and zithromax. There is no reason for them to be on both of them. So they don't need to be on it for too long of a time. So the third one is the inhalers. So if they have underlying bronchospasm or lung disease, and if they're on it, we'll continue it. AIMS protocol for at least moderate disease, they are recommending budesonide. Budesonide is an inhaled corticosteroid. Even if they are not hypoxic, they are using it. The next one is obviously going to be the steroids. Steroids are, there is 2 schools of thought. Some people give it immediately as soon as the COVID is positive. There are some people who give it only after they have the desaturation. So I'm proposing, at least my suggestion is that, if they're already on it, so well and good. But if they are not on it, when they ask you that question, my point is based on the NIH and WHO guidelines and what the data or evidence is showing is that start the steroids when you see this inflection point based on this, when the CRP is raising, NLR is raising, or, oxygen is dropping. So if you have seen that decline around that 5 to 7 days range, that's when we are recommending the steroids. And next one is anti-inflammatory. In India, they have the Dolo and Crocin. The other one is everybody is using vitamin C, zinc, and vitamin D. So Faviflu is also used very commonly, but other most important thing is anticoagulation. I think 7 to 8% of the COVID patients in the next 6 to 8 weeks time are getting some kind of a venous thromboembolism, either in the legs or in the pulmonary embolism. And there are some certain other areas also. So to prevent it, it's a good idea to give aspirin or some kind of a oral anticoagulant. The apixaban, or it is called Eliquis over here in the United States, is commonly used, and its a usual treatment dose is 5 milligrams 2 times a day, whereas the prophylactic dose is 2.5 milligrams 2 times a day. So the prophylactic dose, if they have access to it, there is a shortage expected, or it's already happening in certain areas of India, so they can go to aspirin also. I think if I have to focus on this, I think the steroids at right times and then the anticoagulation are the key. And while you are only suggesting, we are not giving any prescription. So that's mainly about the treatment, the pharmacological treatment of it. But the main part that we focus, or we can give that control back to the patient, is the non-pharmacological therapy. The non-pharmacological therapy, can you move that slide to the right, please? So yeah, here, the proning is one of the important things that we can suggest. And in the proning, you're going to improve that gas exchange. So if they are obese and unable to do it, at least you can, encourage them to do it on the side. And, that will help them to get, to be able to maintain good saturations. And 2 hours, one position, 2 hours, other position, that would be a good proning protocol. Down the road, in a week or so, once there is a physical therapy association and willing enthusiasts, just like the doctors, who will be able to help the patients to do the proning. If you have seen a patient that will benefit from proning, and the physical therapists who help with them, they can also, you can refer to them, and they can probably see that patient and then help them for that proning. So that is in works. Right now, they are not there, but very soon they'll be adding on. So if you have a patient, you can refer to that. That will be coordinated in this next few days. So the other thing is, if they have incentive spirometry, that will be useful. Incentive spirometry is they have a few balls. As they take a deep breath, the balls go up. That visual is going to encourage them to take deeper breaths. So that is very important. Then the exercises, the breathing exercises and walking. So those are going to be very useful too. We already talked about walking pulse ox earlier, and then it goes without saying that they need to follow the vitals on a regular basis. If they can not only just follow them, they need to document it. So the documentation is the key, because like we said earlier, trend is a friend. As they trend this data, it becomes easier for some doctor. It may be somebody else 3 days down the road. If they have that data documented, you can easily put them into different phases, different stages. That way we can help them answer these 3 questions. And then the flutter valve is for patients who have suppurative or some kind of a productive sputum. That will be useful. So the flutter valve will help them to clear up the secretions. If you clear up the secretions, that will be very useful to improve their oxygenation. I know it may not be easily be available, but encouraging the patient to cough as much as possible and bring it out, that would be good. Number 2 is, in this scenario, I suggest that do not encourage them to use anticholinergic agents, which are going to dry up the secretions. So, and especially if they have productive sputum, it may not be coming from COVID, may be coming from some other thing or underlying problem. If they have mucus producing kind of a problem, and you give anticholinergic agents, you are more likely to dry up the secretions and more likely to cause mucus plug. And that can block the gas exchange from a normal or uninvolved area of the lung. So that's why I avoid the ipratropium anticholinergic agents in these patients if possible. Then next step is the hydration. The general guidelines are 3 liters for women, 3.5 liters for men, but it is for normal. when they have underlying congestive heart failure, you need to be careful, and then sodium issues and all that. So I hope that people take it with a grain of salt. Some of these things are not applicable to everybody, but we are kind of coming up with the general guidelines that will apply for 80% of the people. Similarly, if the patient has diabetes, and they're on steroids, one of the things that we can encourage that is that make sure that they're checking the blood sugar, so that the blood sugar raise is not going to push them towards a hospitalization while the COVID is normal. So these are some of the things that you need to focus on the non-pharmacological side, and then give them a good advice on the pharmacological side. So I think what we set out with these three goals, the triage, the prognostication, and management of the management decisions, both pharmacological and non-pharmacological, and relieving the anxiety and the stress of the patient, the family, and then thereby relieving the pressure on the system, emergency rooms, and the public health and the government at large. I think we will be able to do a tremendous job of keeping this pandemic panic levels under control. And one small thing I missed out when I was talking about the labs, I just realized, is the NLR. NLR is one of the common things. It's on the previous page, but I'll tell you, in India, they are using it a lot more. I don't think I put it in there. The neutrophil lymphocyte ratio. So basically that so neutrophil lymphocyte ratio is basically when the lymphocyte count goes down and the neutrophil count is same or increased. So more than 3.5 is more like you have more of a disease, whereas normal is less than 3.5. So that's another inflection point where if the NLR is going up, that might be a good time to start the steroids.
Okay.
I guess I will end there, Srini.
Yeah, thank you, Prasad. It was a wonderful presentation. I think that class was very good. I think let's go. I think there are some questions, but I think how long is the Eliquis you need to give? Depends on the D-dimer. And as some people use up to 1 month and 3 months. What is your recommendation?
And when do you start it actually? Which cases, like moderate cases or even mild cases?
The way I do it is basically if they have other risk factors, like we do. So definitely for mild cases, you don't need to use it. But if they have other risk factors, the obesity, decreased mobility, underlying history of PE or history of PE or DVT in the past, underlying cancers. So those are the cases where you can, when you have more risk factors coming together, you got to use it. But at least moderate disease, definitely need to consider that. In hospitals, obviously, they're all doing it. They're giving increased doses of that prophylactic. Once you take a decision to give the anticoagulation, I think it depends. Some doctor need to decide at what point their risk goes down. So it's a balance between the benefit versus the risk. The risk is bleeding. The benefit is preventing a blood clot. 8% of the patients are getting it. So I think it is a decent risk that we need to consider at least some kind of an anticoagulation.
Okay. Thank you, Prasad.
One more question. Today I was reading in the newspaper that the Roche antibody, Regencov, has been approved in India for outpatients.
Oh.
This combination, casirivimab and imdevimab.
Oh, wow. That's good news.
Yeah, so it got approved today, I believe. So I don't know how many lakhs it's going to cost, but some of our patients will be candidates for that.
We'll come up with the more edited information on that. That's news to me. Thank you for sharing.
Prasad, before you leave, one more question. When do you start the steroid inhalation? You said, did you say mild disease? I missed out on it.
You can do the mild also because, especially when they start seeing the decline, coughing stage, you can do that. Certain patients can do that even early on. Just based on the age they have it. Right? Common practice in India. So I don't have a place but I think in an individual case, you can budesonide is the common one. I would use that. I would use drug regimen like triple therapies because of the anticholinergic.
Garimella, you're breaking off.
I'm sorry. Did you hear that, or shall I repeat?
No,
can you repeat it? About the steroid inhalation.
I would use the steroid. There are no contraindications, especially in a patient who has bronchospasm problems.
I think can everybody else mute when you're not talking? It's an echo.
Also, I think there are a lot of patients waiting, Prasad. I think let's move on. I think you can come back tomorrow and then do some more. I think you already got like 30 minutes. There's a lot of people waiting. It'll be nice. Just let's start seeing patients whoever is comfortable. Ravi, go ahead and move the doctors so that we can see some patients.
Thank you, Srin.